Hello, everyone. Thank you for coming out tonight. We're so excited to kick off the very first of our Legacy Health Healthy Head to Toe series. We have a very fun topic tonight: hormones, hot flashes, and hysteria. We have our three doctors here from our LMG Women's Specialties Clinic: Dr. Melissa Pendergrass, Dr. Virginia San Miguel, and Dr. Megan Bird. And we'll start with Dr. Pendergrass. Thank you for coming.
Thank you guys for being here tonight. And so it's a really great topic because people have a lot of questions about menopause. They know it's coming, but they don't really understand often why it occurs. And so that's the area I'm going to start out with, is just going behind some of the physiology and anatomy that leads to a woman going through menopause and what some of the consequences are. So what is menopause? It is when a woman stops having their monthly menstrual cycles. It's because the egg is no longer releasing, or the ovary is no longer releasing eggs, and you have a significant drop in the hormones that are produced, estrogen, progesterone. Women tend to go through menopause between the ages of 45 and 55. The average is 51 years old. However, 5% of women will still have menopause before the age of 45 and after 55. So there's a huge range for every woman. A woman is considered to be postmenopausal, or as most people would say, that they're in menopause after they have had 12 months of no bleeding. The tricky part about this is that you don't know when that's going to be until you've gone the 12 months. So it's impossible to know when that last period has occurred until, it's looking back in retrospect. Leading up to menopause for years, people can have irregular bleeding and also symptoms such as hot flashes and night sweats and vaginal dryness, mood disorders, as well as difficulty with sleep. And these years are called the perimenopause or the menopausal transition. The reason that this occurs is that there are fluctuations in the hormones, specifically the estradiol, which is the main estrogen that is produced from the ovary, significantly decreases. In fact, it'll decrease over 90% during this transition. And the other hormone that fluctuates significantly is FSH, which is for you guys, the right side of the screen. And that's the hormone that communicates between the brain and the ovary. It's kind of like the messenger. So as the estrogen levels drop, the FSH levels increase. And so we believe that that is probably why people have these very irregular symptoms the years leading up to menopause. The challenging thing about people always want to know what the test is to see if you're in menopause. And often we do test for FSH and estradiol levels, but the problem is that they fluctuate so much day to day and even hour to hour that they really aren't helpful except for very certain situations. For example, if someone's very young and it would be unexpected. So what's the normal experience for someone going into this phase? As a woman is at the end of her reproductive life, so before she's entered this menopausal transition, she may notice that her periods are getting closer together, and she may have clustering of mild hot flashes around her period. Another thing that can happen is some vaginal dryness that occurs with sex that hadn't been an issue before. When she goes into the early part of the menopausal transition, she may now have her periods actually becoming farther apart. So instead of every 25 to 30 days, she may find that they're now every 40 to 50 days. As she gets later through that transition, she may miss periods completely and can go prolonged amount of times without having any period at all. And then also, as we'll talk about, have other symptoms. Eventually, the woman will stop having periods altogether. And as I said, she's considered menopausal or postmenopausal when she's gone 12 months without a period. And another thing that we're still learning now through research is that we used to think that the ovary didn't do anything once it became menopausal, but actually there might be a little bit of production of still testosterone from the ovary even after someone has gone through 12 months of no bleeding. So what are the main symptoms? The number one is hot flashes, and that's what people talk about all the time. They can be very bothersome. These are also known as hot flushes. Also, in medical terms, we call these vasomotor symptoms. And this is when you have if you haven't experienced it, it's an intense, and I haven't luckily yet, but intense feeling of heat in your face and your chest that spreads rapidly through the body and lasts usually 2 to 4 minutes. People can often have shivering and sweating and often feel very cold afterwards as well. So it's these kind of extremes in temperature. And again, we think this is likely due to those fluctuations in the estrogen levels as well as the FSH. They're very common. So in the early part of the menopausal transition, 40% of women will have hot flashes, whereas you get into the late part of that transition and also the early years being postmenopausal, 60 to 80% of women will have them. If you are having them, or at least 80% of women who have hot flashes have them daily, and a third will have 10 or more during the day, so they can be very disruptive. If they go untreated, most women will have a resolution in those hot flashes within 5 years, although this is not always the case. And supposedly, one study showed that 9% of women will have some hot flashes up into their 70s, which is unfortunate. Hopefully those are mild, but we aren't 100% sure why they occur. We know that there's the fluctuations in hormone, and we think it's related to the brain, the part of the brain that regulates temperature. It becomes more sensitive. So if you have an increase in your body core temperature, instead of being able to handle that, your body kind of reacts quicker than it would normally. But we're still looking in and trying to figure out what exactly is happening. The second one is night sweats. And so this is essentially a hot flash that occurs at night. So women can wake up feeling really hot or very cold, having sweat through the sheets, through their clothing. If this is happening multiple times a night, it can be very disruptive for their sleep. And so women, obviously, and anyone who doesn't have a lot of sleep can have other symptoms. Obviously, fatigue is one. They can have difficulty with their memory, poor mood, and difficulty concentrating. But it is interesting to know that even if a woman is not having night sweats, they can still have significant problems with sleep during this menopausal transition. So completely independent. The third thing, and this is something that people don't talk about as much, is the vaginal dryness and some sexual dysfunction that occurs during the perimenopause. And this is because these estrogen levels are dropping significantly. And the vagina and the urethra, which is the tube that connects the bladder to the outside of the body, are estrogen-dependent tissues. And so when you have this significant drop in estrogen, these tissues become thinned. So if someone is sexually active, they can have dryness and pain with intercourse. And even if they're not sexually active, they can have irritation and dryness just with normal activities that can be bothersome. This is called vaginal atrophy. That's the medical term that we use on a regular basis, and is very common. Probably at least 40% of women will have some symptom of vaginal atrophy. The unfortunate thing about this, though, unlike hot flashes, which will eventually go away, vaginal atrophy doesn't. It tends to progress. And so a lot of women need treatment or should be having treatment for it. And luckily, as Dr. San Miguel is going to go over, these options will be discussed, but something to think about. The fourth one is mood changes and depression. So women during the change of life can find all of a sudden they're more tearful. They are not coping as well as they used to, not enjoying activities the way that they had in the past. And this is very common. It has been shown in some research studies that women during the transition, so during this perimenopause, have a higher risk of new onset depression. So women who never had an issue with this before during this perimenopause compared to when they were premenopausal. The good news, though, is that this risk drops once they actually are postmenopausal. So it's really during those years in between that seem to be the most challenging. There are other symptoms such as difficulty with memory. Also, you can have an increase in your joint pain and aches, as well as some breast tenderness and pain that occurs during this transition as well. We always, or a lot of women ask, when are they going to go through menopause? And as I said, we can't predict that completely, but there are some I guess, risk factors or some predictive factors to think about to assess if you are at higher risk of going through menopause earlier than the average. Number one is genetics and your family history. So women who have female family members who went through a natural menopause, so they didn't have a hysterectomy and their ovaries removed, but natural menopause at an early age are also at increased risk of going through an early menopause. So that's something that's helpful to ask actually family members about what their experience was, because it could have some impact on you. The second one is smoking. We know that smokers actually go through menopause 2 years earlier on average than women who don't smoke. So that's another reason to stop smoking if you are. The third one is ethnicity. So women who are Hispanic American tend to go through menopause earlier than Caucasian, and Japanese American women tend to go through menopause later, again, compared to Caucasians. And it's unclear if this is genetics or if this is diet related compared to soy intake in their diet, or if this is more of a cultural perception of women in certain cultures actually just don't talk or perceive their symptoms as being as bothersome as other ones. If you've had a hysterectomy, but your ovaries were left in place, well, I guess first of all, if you had a hysterectomy with your ovaries removed at the same time, if you are premenopausal, you will go through surgical menopause is what we call it, right away. So you will have all the symptoms I talked about, but usually very abruptly, unless you're given some treatment, specifically hormones, ideally to help with that. But if you've had a hysterectomy alone, so just the removal of the uterus, that will not cause menopause. And that is confusing for a lot of women. They think that potentially that will also cause hormonal issues, and it won't, as long as your ovaries are in place. However, there is a trend that women who've had a hysterectomy with their ovaries left in place to maybe go through menopause a little bit earlier. And this could be because of the blood supply at the time of the hysterectomy. The blood supply of the ovary could have been impacted in some way. We aren't really sure why this happens, but another thing to keep in mind. The last one is obesity or being overweight. This isn't necessarily reflect what age you're going to get it, but as a side note, obese women tend to have more symptoms, especially the vasomotor, so the hot flashes and the night sweats, compared to women who have a lower weight. And this is actually very ironic because we know that adipose tissue or fat tissue tends to produce its own source of estrogen, completely independent of the ovary. So you would think women who have higher sources of estrogen would actually not have as many symptoms of, estrogen withdrawal. But in fact, they tend to have more, and it may be almost like an insulation issue and an inability of the body to dissipate the heat, as well as thinner women. So something to keep in mind. So now we should probably talk about what are the actual consequences of going through menopause. Obviously, the symptoms are bothersome and can affect your quality of life, but there's actually some significant medical issues that occur during this transition afterwards as well. The number one thing to talk about is osteoporosis. So a woman up until the age of 30 is building her bone mineral density, and it tends to max out at 30, which is unfortunate, and plateaus for most of the rest of her reproductive life. The year before that last menstrual period and 2 years after is the highest rate of bone turnover and breakdown in a woman's entire life. After that, it tends to, it's still declining, but it tends to slow down. And so that's something to keep in mind. And it is really important to talk to your physician or healthcare provider about making sure you're optimizing your bone health with exercise and diet, and potentially medications as well. The second one is cardiovascular disease. We know that estrogen has some influence on our cardiac protection, and this is related to the fact that women who are premenopausal tend to have less heart disease and heart issues compared to men and compared to women when they become postmenopausal. However, the evidence is still a little controversial about how giving hormone replacement actually affects a woman's cardiac health, and Dr. San Miguel is going to talk about that a little bit further about behind those research studies. But we do know that it definitely has an influence, and it could be related to worsening risk factors, such as we know cholesterol tends to worsen as a woman is going through menopause. So potentially things like that could happen. And that kind of leads into the next one, which is changes in body composition. So this means that women during this transition and afterwards tend to have a risk of increasing fat mass with a loss of muscle mass. And, it's again, all these studies are controversial about giving estrogen supplementation, how that does that decrease that risk? And some studies do show that it does help prevent, especially central fat deposition in women who are going through menopause. Another issue is dementia, and we know, or we strongly think that estrogen is considered protective of brain function. And we had high hopes at one point, and again, we'll talk about this later, that estrogen would prevent dementia if given long term. However, the studies, again, are controversial, but we do know that it can help with brain function. The last one is balance. During this transition and afterwards, with these lower hormone levels, women can have sudden issues with balance, which they didn't have before. And this also can contribute to the fact that women tend to get forearm fractures as they fall, besides having the bone mass issue. But that's another reason that women at that age tend to have higher fractures, specifically in that area. So another thing to keep in mind, and potentially hormone replacement can help with that. Other things that can be consequences are skin changes as well. That's something that people can notice, and that's related to collagen in just like the bones. It's also in the skin as well. So potentially there can be increased kind of aging or wrinkling occurring in people's skin. So that's something to keep in mind. The good news and bad news is that this is a normal part of every woman's life. And there's a lot of options that my colleagues are going to go through with regards to treatment, but not everyone needs treatment. It's just a matter of quality of life. If you're having heavy periods and irregular periods during this transition, or any bleeding after you've gone through menopause, you absolutely should see a physician or a healthcare provider, because that's not normal. So it can be confusing to know what's normal and what's not. But so I always recommend asking someone if you're at all confused. But now I will hand it over to my colleague, Dr. San Miguel.
So now we're going to focus on treatment, menopausal hormone replacement. This is for the symptoms that Dr. Pendergrass has discussed. And as she mentioned, we think it's a result of declining production of estrogen in the woman's body. So it makes sense that estrogen is the therapy, and it's been used for this purpose since it was FDA approved in 1942. For about 20 years, we used estrogen by itself, and then in about the 70s, we learned that we needed to add progesterone to the estrogen therapy in order to protect the uterus from overstimulation and cancer. Today's hormone options include estrogen alone, estrogen with progesterone, and progesterone alone. It comes in a multitude of formulations and products. The hormones come in pills, patches, creams, sprays, gels, vaginal administration, rings, pills, creams. There's suppositories, just about any form of administration you can think of. Usually, if a woman has a uterus, they're going to be on a combination of estrogen progesterone. It can be a variation of a patch or a pill, or a combination one pill formulation of both. If you've had a hysterectomy, more likely you're only going to use estrogen. And then if your symptoms are strictly vaginal, there are formulations, like I mentioned before, where you can use vaginal estrogen by itself. Today's doses of vaginal estrogen are so low that women can use them even if they have a uterus without progesterone. Other less common types of hormones that are replaced include testosterone, the phytoestrogens, which are found in food products like soybeans, chickpeas, flaxseed. You've probably heard of those as natural sources of a estrogen type of hormone. There are also the compounded bioidentical hormones and the herbal supplements. And these last two are the most controversial. And that's because compounded drugs and supplements aren't very well regulated or controlled. They're not approved. And so there's very little scientific data to support their safety and their effectiveness. It's very hard to know whether what you're buying in a supplement is actually what's in the bottle or whether the label is accurate or not. Nobody checks on that. So let's take a minute, though, to talk about the compounded bioidentical hormones. These are the ones that cause the most confusion. The actual term bioidentical hormone doesn't have a very precise medical definition. So endocrinologists would tell you that these are compounds that have the exact same chemical and molecular structure as the hormones that are produced in a human body. Clinicians normally use the term to mean any compound that any preparation that has progesterone or one of the three types of estrogen, which can be estradiol, estrone, and estriol. But the bioidentical hormone advocates, like Suzanne Summers and others, tend to think of bioidentical hormones and bioidentical hormone therapy as more than just that. They think of it as a whole regimen where a woman's hormone levels are tested, usually through a saliva test, and hormone deficiencies are identified. Then they get a prescription that includes a mix of hormones to correct those deficiencies and bring her hormones back into balance. The prescription is usually filled at a compounding pharmacy that makes the preparation from natural substances like soybean or Mexican yams. Besides estrogen, the prescription can include other hormones like testosterone, DHEA. Sometimes they include adrenal extracts from animal glands. And then periodically, the woman's levels are checked again, and the prescription is changed as is necessary. And I just want to make a couple of comments about that. The saliva tests are not an accurate measurement of a woman's hormone levels. Those levels change constantly throughout the day. They change from day to day. And it's very difficult to say that you're exactly duplicating a woman's hormones by taking one single test. So the fact that and sometimes these bioidenticals are advertised as being customized to you, to the individual woman, and it's hard to that's a very appealing idea, but it's really misleading because it's really hard to do that. It's not any more accurate than getting a prescription dose that is based on large population measurements. And the second thing I want to say about it is that you don't have to get a compounded preparation to get a bioidentical hormone. There are several hormones on the market that are exact chemical and structural duplicates of what is produced in the body, and they are FDA approved. And those include estrase, Climera, Vival Dot, which is a patch, Prometrium, which is a natural progesterone. So whether you get treated for your menopause symptoms or not, and what you get treated with is your choice after you've hopefully gathered some information enough to make an informed choice. And I think maybe to help you with that, I should share with you some of the science behind hormone therapy. So for decades after its approval, it was widely believed that estrogen not only treated hot flashes and other menopause symptoms, but that it extended a woman's life and prevented disease. So we used to prescribe estrogen after menopause, and it was basically for the rest of her life because we believed that it improved her health. And after all, it's long been observed, and Melissa mentioned it, men have a shorter lifespan. They have more heart attacks, more heart disease, more strokes than women up until menopause. And then women really catch up to men. So it just made sense that a woman's hormones would be protecting her from the heart disease especially. And scientifically, this belief was bolstered by 50 years of experience and observational studies. The most convincing of the scientific data was based on a large study started in 1976, and you may have heard of it, the Nurses' Health Study. It involved about 120,000 nurses, women ages 30 to 55, so relatively young. The oldest were not more than about 5 years past the average age of menopause. Every 2 years, these nurses would be given a questionnaire about their health and their lifestyle. And up into the early 90s, the data from these studies were showing that there was an increased incidence of breast cancer and gallbladder disease. But there were also some health benefits, and that in particular was a reduced risk of heart disease. This was an observational study. It wasn't conclusive, and part of the reason that it wasn't that conclusive was the question of whether the nurses who chose to take hormones were maybe healthier to begin with than other people. So in order to test that healthy woman bias, the National Institutes of Health in the 90s conducted several studies. The first one, called the PEPI trial, involved about 875 women, a little bit older, 45 to 64. And those findings seem to confirm the nurses' study findings. The second study, published in 1998, was the HERS study, and it involved about 2,700 women who were already postmenopausal. They had existing heart disease, and they added estrogen and progesterone to see if that would prevent heart attacks. And it didn't. So the results showed that adding estrogen to postmenopausal women who already had heart disease would not prevent heart attacks. So now it's the mid-1990s, and menopausal hormone therapy is the second most prescribed drug in America, and we still don't know whether it prevents heart disease or not. So along comes the Women's Health Initiative study that I'm sure you've all heard about. It was a large, well-constructed study. It was about 160,000 women. They were older, 50 to 79. This was a prospective, randomized, placebo-controlled trial, so a good study. But that study really cast doubt on whether or not hormones could protect women from heart disease, and it really dramatically changed the way that women and their doctors viewed hormone replacement. There are many criticisms of that WHI, the Women's Health Initiative, including the fact that the age of the women was older. The average age was 63. A full 70% of those women were 10 years or more past menopause, and they weren't screened for pre-existing heart disease. But it remains a solid study, and a study that continues to be looked at even now. It put women in two groups. One, women who had a hysterectomy and therefore didn't have a uterus anymore, and the other group that still had a uterus. The women with a uterus used estrogen plus progesterone or placebo, and then the women without a uterus used estrogen alone or placebo. In 2002, which was about 5 years into the study, the estrogen plus progesterone arm was stopped early for safety reasons. Their concern was that not only was the data showing that it didn't prevent heart disease, but it was actually showing an increased risk of heart disease and breast cancer. So they stopped that arm 5 years into it, and the estrogen-only arm continued for another 2 years. There was a 41% increase in stroke. And if you look at it in terms of numbers, which is a little bit easier to understand, there were 8 more cases per year per 10,000 women. There was a 26% increase in breast cancer, which equaled about 8 more cases. And this is in the people who were taking estrogen plus progesterone. 7 more cases of heart disease, 29% increase. And there were also some benefits. 5 fewer hip fractures, 6 fewer colon cancers. And the other interesting thing is that in the estrogen alone, which is not up there, the estrogen arm had, again, an increased risk of stroke, 12 more cases, but decreased risk of breast cancer with 7 fewer cases and then 5 fewer heart disease cases, which wasn't really considered significant. In totality, though, the study was viewed as estrogen and progesterone increases your risk of heart disease and breast cancer. So today, it's a decade after WHI, but there is still, with the increasing number of postmenopausal women in this country, there's still a strong interest in continuing to study this important drug and the long-term health effects. There's been a number of experts who have revisited and reanalyzed the WHI results. Dr. Jeffrey Bender at Yale School of Medicine has some really interesting, has had some interesting data. He argues that in the Women's Health Initiative, there could have been significant vascular disease, since they didn't screen for it, already present in the study population. Remember, they were older, average age of 63 at the time of the initiation of the study, and that estrogen just may not reverse already established disease. In support of his argument, he cites an animal study where primates were they had their ovaries removed and immediately were treated with estrogen replacement versus placebo. And then the second group, there was a delay between the time that the ovaries were removed and the estrogen was replaced. In the immediate replacement, they saw a 70% reduction in coronary artery disease. The primates who had the delay in treatment didn't see any benefit. And then the other really interesting thing for me is there's been an analysis, a study of a subset of the Women's Health Initiative data. What they did is they carved out the young women out of that estrogen progesterone study, the women that were aged 50 to 59. And in that group, they had actually had a significant reduction in their incidence of heart disease. So that evidence suggests that if given in low doses early in the transition period, that estrogen might still protect women against heart disease. And there's a couple of other studies that have been recently published and continue. There was one last year where women were within 3 years of menopause, and they looked at both oral hormone replacement, estrogen patches, and placebo, and they saw no increase in cardiovascular risk. There's a study that's been just finished last year that is comparing early versus late administration of estrogen, women within 6 years of menopause, and then women after 10 years. And the results are not published. The study is done, but there's no published results yet. So, what do you do with all this information? It's really hard for the average person to keep up with that kind of scientific literature, and the studies can be confusing. They're hard to understand. So it may help you to know to ask what the experts think. Do the experts agree on this? And I can tell you that it seems like they do. The ACOG, which is our organization, the American College of Obstetrics and Gynecology, agrees with a panel of about 14 national and international menopause societies and universities that participated last year in a panel to sort out the evidence and to try to find areas of agreement. And they actually came out with a consensus statement that takes the position that most healthy, recently menopausal women can use hormone therapy safely, that the benefits are more likely to outweigh the risks when it's used by symptomatic women before the age of 60 and within 10 years of menopause. They make about 12 recommendations, and I'll only highlight the top 4. they say that that menopausal hormone replacement is the most effective treatment for menopause symptoms, and that if women have vaginal symptoms only, it's recommended that they use vaginal estrogen only. That hormone replacement is effective for the prevention of osteoporosis and fractures. They confirmed that both estrogen and progesterone, and estrogen alone increase the risk of blood clots. And we've always known that blood clots to the heart, and to the legs and the lungs, just the same as birth control pills and patches also increase that risk. And that risk, but they say in spite of that, the risk of blood clots and stroke is very rare in women up to the age of 59. An increased risk of breast cancer is confirmed. They agree that the increased risk of breast cancer is seen within 5 years or more of continuous estrogen and progesterone, but that risk decreases once the therapy is stopped. And estrogen alone, used for an average of 7 years, was not shown to increase the risk of breast cancer. So the bottom line is that hormone therapy is an acceptable option for the relatively young, healthy woman up to 59 and within 10 years of menopause who's bothered by severe or moderately severe menopause symptoms. Individualization is key in making this decision. Consideration needs to be given to the woman's lifestyle priorities and her own particular risk factors. So I hope that helps. That's the end of my talk. And Megan Bird is next.
Hi. So I know this is a ton of information all at once, and I have quite a bit more. Sorry, but I'm supposed to talk to you about the alternatives to hormones, and then a little bit about sexual dysfunction at the end. And one of the things that I want to talk about first is risk. There's risk to everything in life. You're all old enough to know that. When you drove here or walked here, you took some risks. When you eat something, you take some risks. Medications are the same way. Every medication you take has some risks, hopefully some benefits, and it's only worth taking a medication that's giving you more benefits than you're taking in risks. Unfortunately, for most of us, we don't necessarily know what the risks and benefits are going to be when we start a medication. There is a leap of faith that we're going to get some benefits. We don't always get those benefits. There's a leap of faith that we won't get the biggest risks, but that's a leap of faith. So keep that in mind when we talk about all of these medications. There's no perfect answer. But on to all the options. There's a lot of options out there, and some of them are good and some of them are not so good, but we'll talk about it. So the first option is placebo and doing nothing. So believe it or not, hot flushes get better. So people who take placebo 20 to 40% of the time get better. And some of that's psychological. It feels good to be doing something about your hot flushes, even if it's not necessarily changing anything. You feel good that you're doing something. And some of it is just that hot flushes will get better. So one option is just to do nothing, live with it. It really depends on how much the symptoms are bothering you. If they're keeping you up at night, if they're starting to interfere with your relationships, it's probably time to start thinking about options for treatment. And then we have 3 options that are better than placebo. Not as good as hormones, but better than placebo. And that's the antidepressants, gabapentin, and clonidine. Antidepressants, which are SSRIs and SNRIs, Effexor and Paxil are the most common ones we use, are effective 60% of the time. And that's true even if you're not depressed. So even if you don't have any depression, you're just having hot flushes, you still will get some relief 60% of the time. Unfortunately, they have risks: nausea, dry mouth, fatigue. The biggest concern is actually sexual dysfunction. They inhibit sexual desire for some women, interfere with orgasm for other women. So it kind of depends. But again, that gets into that leap of faith for risks and benefits. Most women tolerate antidepressants just fine. Some women don't. Gabapentin is the next one. Gabapentin is actually a seizure medication. We use it in a lot of different other things, chronic pain, a bunch of other stuff. It works about 60% of the time. I'm going to say that a lot. Some people feel tired or sluggish. The biggest thing that happens with gabapentin is actually some diarrhea, GI cramping. And gabapentin is one of those medications that you got to start slow and build up slowly. You can't just sort of jump to full treatment right away. You'll be pretty miserable. But it definitely is an option for some women. Clonidine is a blood pressure medication. We have no idea how clonidine works to prevent hot flushes, but it does. Probably for about half of women who take it. It can cause dizziness or fatigue. It can also cause problems sleeping, which is really counterproductive in menopause. But for some women, it works fantastic. The problem is it is a blood pressure medication. So if you're on blood pressure medications, it can really interfere with your other blood pressure medications. It can lower your blood pressure. So we generally say take it at night to reduce that, but some people can't handle the blood pressure drop. So those are the things that are better than placebo. And then there are 3 things that we're going to talk about that we just really don't know if they're better than placebo or not. They may not be. We just don't have quite so much information on them. Soy products is the first one. Now, soy is really confusing. There is a ton of studies on soy products in menopause, and the results are all over the place. Some of them say it helps, some of them say it doesn't. Really vary. The literature, the evidence is really confusing for us. So we're just not sure what to do with it. When we kind of group things together, it seems like eating a soy-rich diet helps more than taking supplements. So eating tofu, eating edamame, eating soy products is better than just supplements. Fortunately, soy is pretty safe, so it's not so bad to take it. So it's definitely, for some women, worth a try in the beginning. The next one is acupuncture. Acupuncture has 2 really good studies that show it is better than placebo when combined with other things, hormones, clonidine, and antidepressants. We don't know if on its own it's going to be better. That study hasn't been done, but it certainly, as an addition to other things, seems to improve outcomes, make hot flushes better. Also a really safe alternative. The last one is probably the most controversial, black cohosh. We don't like to talk about it because it's very, very hard, but again, a bunch of studies, conflicting results. Some say it's the best thing ever. Some say it doesn't work at all. So we really don't know where to go with it. We don't know if it's because doses are different, people are different, or what really is going on with that. Black cohosh does have one risk, and it can actually cause significant liver disease. So if you're taking it or you're thinking about taking it, you really need to have your liver functions tested by your physician. There's nothing wrong with trying it as long as you understand that you're taking a small risk and get yourself tested first. And then we're going to talk about 3 things that just don't seem to work. The evidence is against them. They don't seem to work. Ginseng is one of those things. It doesn't seem to help hot flushes at all. It does seem to help mood and sleep. So it might be worth taking for those reasons, but not necessarily for your hot flushes. Dong Quai is a Chinese herbal medication that, whether we combine it with other things or leave it alone, it doesn't actually seem to do any good. It also has a liver risk. So it can actually injure your liver as well. So that one is a little bit concerning for us because it doesn't seem to help. And kava, which is actually a Polynesian herbal, doesn't seem to help either. If anyone here has ever taken kava in the liquid form, I can attest to the fact that it tastes like dirt and it will make your mouth numb. But it doesn't help your hot flushes at all. And then the next thing we're going to talk about, the dry, cracked riverbed. So one of the biggest issues for menopause is really sexual dysfunction. A lot of people tolerate the hot flushes. They live with all these other things, but boy, they would like to have sex again. That would be awesome. And so we're going to talk a little bit about some things that we're treating for sexual dysfunction. Testosterone, like Dr. Pendergrass said, the ovary makes testosterone for about 10 years after menopause. It makes a little bit. That doesn't seem to help every woman in terms of sexual function. In addition, it ends at some point. And so testosterone has been studied a lot for sexual function. And the studies aren't quite clear. And we think that's probably because different doses have been used in studies, different populations have been used. Women are going to be different. Some women are going to require more testosterone than other women. But overall, when we take them together, it seems that taking testosterone helps most women with sexual dysfunction. And some of that is helping in increased libido, sexual desire, and some of it's helping in ability to have an orgasm. Unfortunately, testosterone has risks. I'm going to sound like a little bit of a broken record that everything has risks. Acne, male pattern hair growth, so facial hair, body hair, clitoral enlargement can happen. That's a plus minus whether people think that's good or bad, but It can happen. Voice deepening if you take too much of it. The other thing about testosterone is it can actually raise your cholesterol and raise your heart disease risk. And there's actually a really interesting study that just came out that men taking testosterone increase their heart risk, and women aren't going to be significantly probably different than that. So testosterone, risks and benefits, may be worth it, may not be. And then two medications that are commonly given by naturopaths, DHEA and oxytocin. And these are supplements / medications. We don't know. They're usually marketed as supplements. But there isn't a lot of evidence on them. We have a little bit of evidence on the DHEAS, and we're not quite sure if it works or not. Again, they're kind of back and forth about whether or not it works. We have hardly any information on oxytocin about any part of it. And part of a physician, at least from my perspective, my reluctance to use it is I don't know what a safe dose is. I don't know what risks and benefits to tell you about. I don't know what risks you'd be taking it. And I don't know what to worry about, what not to worry about it with it. So it's a little bit concerning. I think there are people who are actively looking into those things as alternatives, but right now we just don't know. So benefits are decidedly unclear. And then lastly, I'm supposed to talk about vaginal dryness and atrophy, which is nobody's favorite, really. And really the thing that gets everybody worked up because it doesn't go away and it really generally gets worse. So over-the-counter stuff. We're going to start with moisturizers. You're going to see these advertised on TV as replacing your natural moisture. They're water-based. They can be used as a lubricant for sex, but they are designed to cling to the vaginal walls and replace some moisture that normally is there. And for some women who have mild atrophy, it works fantastic. You use it 2-3 times a week. You can use it just when you have intercourse, and it actually helps people quite a bit. And actually, we'll talk about this in a minute, but there's some in the back to try if you'd like. Not try on your hands. Don't go getting undressed here. There are windows. We'll get in trouble. The other is lubricants. I have a personal belief that pretty much anyone over 40 should have lubricant in their house. I just think there's no harm in it at all. There are dozens of types of lubricants. There are oil-based ones, water-based ones, and silicone-based ones. Silicone-based ones tend to be better for postmenopausal women because the slickness actually lasts longer, and sometimes we need that longer slickness. But they work great. And actually, there are places where you can actually just feel the lubricants. I've got some back there too, to see what they feel like before you spend $20 on a bottle of lubricant. But a huge, huge benefit for a lot of women who only have discomfort when they have intercourse. That seems to help quite a bit. We are a couple of notes about lubricants. Oil-based lubricants you don't use with condoms because they break them down. And silicone-based lubricants you don't use with silicone-based sex toys because it breaks them down. But other than that, you're all good. We are actually super, super fortunate in Portland. We actually have a female-friendly sex shop, and they didn't pay me to do this plug, but they should be. Shebop is up in North Portland, and it actually is a female-friendly shop. It is run by women for women, essentially. And yes, it has everything in there, but they actually have a whole big display of lubricants that you can try and feel and moisturizers that you can try and feel beforehand to go see. And so I strongly recommend that everybody have a favorite lubricant. But there are other things for vaginal dryness and atrophy. Dr. San Miguel mentioned vaginal estrogens, just a little bit of a discussion of that. Like she said, there's actually very little absorption of the estrogen past the vagina. And that's actually really important because it avoids a lot of the risks that we worry about with estrogen in terms of uterine cancer and breast cancer and heart attack and stroke. The best studies show that it doesn't seem to affect those things. So vaginal estrogen is a great option for people who the lubricants, the moisturizers, they're great, but they're just not doing it. Really good option. Some women notice an increase in vaginal discharge. That's not unusual because you're rejuvenating those tissues, and so you're going to have some discharge like you did when you were 30. Not the worst thing in the world, but some people are really bothered by it. They also improve bladder function because, like Dr. Pendergrass said, the urethra is affected as well. Some people have improvement in urinary leakage and improvement in less UTIs and things like that. So it's not such a bad thing. So that's a good thing. They come, I swear, in any possible way you can imagine: rings and pills and creams and ointments and suppositories and all sorts of things that you can put in your vagina to get the estrogen in there. You'll notice that gynecologists use the vagina a lot. The last thing I want to talk to you about, I know this is a ton of information, and it's really just supposed to prompt your discussion with your doctor, really. But the last thing I want to talk to you about is SERMs. SERMs is our selective estrogen receptor modules. So you have estrogen receptors all throughout your body, like Dr. Pendergrass talked about, in your bone, in your breast, in your uterus, in your vagina. And SERMs work like an estrogen in some of those tissues and an anti-estrogen in other tissues. And so they work, the particular one for vaginal atrophy, works like an estrogen in the vagina, but works like an anti-estrogen in the breast. And that's super important for women who've had breast cancer. Women who've had breast cancer are often told you should never, ever, ever, ever use an estrogen or a progesterone. Please don't. You're going to be increasing your risk of breast cancer recurrence. And this SERM, oxytocin, actually goes around that being an anti and protective of breast cancer. So it actually gives us some options for people who've had breast cancer, which is awesome. This is our goal, is that it's your body, you know it best, and that you really should become the genius of your own body and explore all your options. So you guys can totally stand up or raise your hand for questions if you want to. Sometimes that's a little bit, hard to do in a group of people you don't know. So we've got a few questions up on the computer, so we'll start there. Virginia, you want to answer what percentage of your patients are opting to treat with hormones?
I would say that by the time they come to see me, they've already decided that their symptoms are bad enough to ask for help. So postmenopausal women or women going through menopause, I would say a good 60 to 70%. It's more than half.
Yeah, that's been my experience. At least half of my patients take some sort of hormone at some point, or at least try it. Some of them decide that once they try it, the risk, their side effects are worth more or riskier than the benefits they're having, but probably at least 50%. Do you need a prescription for vaginal estrogen? And will my PCP prescriber, will I need to see a GYN? That's a good one too.
I'll answer that. Yes, you do need a prescription for estrogen. And yes, your PCP can also prescribe it. You wouldn't have to do any kind of exam if you have vaginal dryness and pain with intercourse. I mean, they may want to send you to a gynecologist just to rule out another problem. But if it's just straight menopausal vaginal dryness, I wouldn't think there would be any problem with your PCP prescribing it. But you do need a prescription for it.
I've heard that acne along the jawline can be a sign of hormone changes. Is that true? Dr. Pendergrass.
That can be an issue, especially when you're having the changes, the disruption with fluctuations in the estrogen and progesterone. Sometimes more progesterone in your body can have more facial acne, and also testosterone can obviously, as we talked about, can have issues with acne as well as other symptoms. So do you guys have anything to add to that?
It can indicate an imbalance in the androgens, which we call the male hormones, and estrogen. So there's a condition called hyperandrogenism, and which means the same thing, that there's more testosterone, more on the testosterone side of the hormones, and there are treatments for that.
How can I stop feeling / being so bitchy and get back to being a good wife? It's a fair question. I think one of the guys in the back wrote it, though. I'm going to blame them for that one.
I often tell my patients one of the first symptoms of signs of menopause is that people around you will tell you, will make comments like that. Why are you being so? But it is. And it's one of the earlier signs of menopause, and I think it gets better very quickly, even without treatment. But estrogen would certainly help for that.
I would add a lot of the stuff that we think of as sort of menopause, I think, especially what I hear sort of reading books and that sort of thing, is actually sleep deprivation. There's a lot of sleep deprivation, and sleep deprivation makes nothing better. You do not cope with anything better when you're tired. Nothing is good when you haven't slept. And so a lot of it, I think, is sleep issues, if you can help those sleep issues. Now, part of the problem is you hit menopause and sometimes your kids are in that period of you're worrying about them. You've got other stuff to do. You may have other stresses in life. It's just not easy to sleep. So I think a lot of it, I would say the first thing to fix is sleep, because a lot of patients are coming saying, I'm not sleeping. And that's contributing to the mood, contributing to the crummy feelings and all that good stuff. So I would say the first thing. The second thing, communication. There's a lot to be said for being able to tell your partner, look, this is going to be rough. It will end. It will get better. Do you know what I mean? And have them believe you. And so I think communicating with your partner that, this is coming, it's going to be challenging, but some patience is in order. So the question, just for the cameras, just because they don't hear it, is about low-dose estrogen birth control, low-dose estrogen in birth control pills for perimenopause and that sort of thing. And I'll let Melissa maybe.
Well, another thing that's an advantage for the low-dose birth control is that you can still get pregnant if you're still having periods. And so people think, oh, I'm too old, that's not going to happen. But it does. I've delivered a 50-year-old spontaneous pregnancy when I was training. And so unless you've stopped having your periods for 12 months, it's small, negligible risk, but it's still there. So that's an advantage of birth control. And so we now have much lower dose pills that are perfect for women in their 40s transitioning. It's always a little bit of a struggle knowing when to stop the birth control pill. And so that's something that you tailor with your doctor, and sometimes you kind of wean off and see how you're feeling and just fluctuate it. But I think it's a really good option for women.
Yeah, I agree. I think it's a perfect option. I tend to see women in their 40s who start having changes very, very gradually, the menstrual changes. And I think that's and I have a good percentage of my patients that go on a low-dose birth control pill and we don't stop until average age of menopause, which is 51, and then we'll test, and then they can have the option of stopping and going on something else. But it works very well.
And keep in mind, physiologically, you're overriding your own system, so you're overriding the ups and downs with sort of this even amount. Your ovaries will quit at the same time they were going to quit anyway, right? So you're really just sort of keeping yourself even during that menopause transition. Yeah, the question is about the item that is for women with breast cancer, and that's a SERM. It's oxytocin. I probably couldn't, to be honest with you. It's a favorite, but
OSIFPHEM is close.
But afterwards, find me and we will. I'll look it up and we'll find it, because it really does work. The question is, with the SERM, if you've been diagnosed BRCA1, BRCA2, and it is still an option, you should have a consult with probably the person who's going to be prescribing, and also either a medical oncologist, whoever is following your breast stuff. The issue becomes whether that's completely adequate for protection, or whether or not you should be taking tamoxifen or not, which is tamoxifen is a SERM. It's the same class family of it, but is specifically designed to prevent and protect the breast, and whether or not you should be taking, which one you should be taking. So the question is on Ambien and sleep. And I've found this too, that there are a tremendous amount of people who are on nightly Ambien for years and years and years and years and years. On the other hand, some physicians are really uncomfortable with that. And so she wants our opinion on chronic Ambien versus other options.
Ambien is addictive. And a lot of people, I know people who start taking it for whatever reason, and it's hard to actually get off it. So that's something to keep in mind, and people don't, talk about that very often. You can also have significant, almost like hallucinations and very vivid dreams. So there's a lot of side effects associated with Ambien. So that's the other side to prescribing it, being on it chronically. When we talk about sleep options, the number one is lifestyle changes. So decreasing, alcohol helps some people get to sleep, but also it can actually prevent people from sleeping as well. So decreasing alcohol, not eating heavy meals or eating earlier in the day, not drinking a lot of fluids right before you go to bed to decrease the risk of having to wake up for urination, which can increase as you get older. Not exercising right before bed, not watching TV right before bed, which is really common probably as opposed to reading books or doing other things. There's other medical options as well. Even like Tylenol PM is essentially Benadryl. So I would think a safer medication is just the normal one pill of Benadryl can help some people. Those are my initial thoughts.
Yeah, I go through a whole list of starting with the least, the safest with the least side effects, including things like Tylenol PM, melatonin, those sorts of things. And then, going up into the sleep aids. For menopausal women, progesterone has actually been shown in some studies to be very good for sleep. Natural progesterone. If you remember earlier, I referred to it. It's the brand name is Prometrium, but there's a generic. So natural progesterone at bedtime is a very good sleep aid. And for women who may be having some mild menopause symptoms, that might be enough, and they avoid the risk of the estrogen. So we talk about all those possibilities, but a lot of people are really cautious about going on Ambien and Lunesta and Sonata, and I don't see those as daily drugs. I see them, and very few of my patients are on them. I just don't. I just don't find that they're that popular.
I do find that they're popular. Not that I give them for daily use. I do think that the risks are pretty high with daily Ambien. But then it sort of leaves you in this lurch of like, what do you do? And there are sleep hygiene stuff like Dr. Pendergrass was talking about, cool rooms, dark rooms, don't do anything else in bed besides sex and sleep. It's true. That's what they say. If you have trouble getting to sleep and it's been a half hour, you get up, do something else for a few minutes, come back. So you're not just associating misery with your bed. That's a lot of it. But then you do get into these situations where that really doesn't do anything and the Benadryl isn't helping and the progesterone, maybe you have other things with progesterone. So I think people kind of get into a bind of Ambien, but it is addictive and it has risks if you start taking it every day. So I wouldn't be super jazzed for taking it every day either, but... The question is hormone replacement an issue for women who have high cholesterol and sort of baseline risk for heart disease that may be higher than the average?
Yes, so that's the whole customization and individualization issue with hormone replacement. Is you have to look at the woman in front of you, the particular individual, and figure out what their risks are. And if you have high cholesterol already and you have either you have heart disease or you have a family history of heart disease, then you have higher risk factors. That doesn't mean you can't take hormone replacement, but then you might want to take a very low dose. You may want to take it for a very short period of time. You have to balance it against how severe your symptoms are, your menopause symptoms. And you can also, make sure you control you medicate if you need to control to lower your cholesterol level. So you have to discuss all of those things and then step into it with your eyes wide open and realizing that there's some risk, but you're going to do it for this reason and for this length of time.
So the question is, in someone who, in your example, went through menopause early, but it actually wasn't terrible. I mean, some women skate. It's true. Life is unfair. Accept it. Some women skate and really don't have terrible hot flushes or have hot flushes that they can manage. And should they take hormone replacement therapy for other reasons, or should they just, move on?
Yeah, I think you got the message that at this point, the science doesn't show that it helps for someone in your position to restart it. You're well past that. And the science may still show that if it started early in the transition, it still can help. But, almost 10 years out, it wouldn't. Your issue would be with the symptoms that Melissa mentioned that get worse, the vaginal dryness, pain with intercourse, and then vaginal estrogen would be your option.
Currently, hormone replacement therapy is the recommendations are that it is for prevention of hot flushes. We all use it. I mean, some people use it for lots of different reasons, but that's given the fact that we don't know all this other stuff. Do you know what I mean? We don't know. That's the only indication that they say we should be using it for. Bones, we actually have other options for in terms of bisphosphonates and Fosamax and things like that. So that's currently what the group says is you take hormone replacement therapy for hot flushes. Do I prescribe it for other things? Yes. Depends on goals. What is your goal? Is your goal to feel like you were when you were 20? Which, in all seriousness, there are women in the world who are taking significant risks with their medication to feel 20 again. Most women are saying, I just want to sleep. I just want to get through the next few years. Do you know what I mean? My goals are much more modest. And so it depends a lot on your goal. But currently, hot flushes. And so if you're not having hot flushes or they're not bothering you, do all your cardio prevention, all the good stuff, exercise, eat healthy. But you don't necessarily have to take hormones. So a lot of these, essentially you're getting on, when you come off of hormones, you've been put on hormones for whatever reasons, you come off of hormones and then you get this sort of resurgence of symptoms, let's put it that way. Bleeding like a river, that certainly happens. And how long should that last and how much time should you go? And
that every woman's different about how they phase off of their hormones. And some women, I think it depends on where you are in that cycle. A lot of women who stop their patch, if it's been well over the time of menopause, won't necessarily have bleeding, but they'll have the resurgence of hot flashes and night sweats. And there's actually good tapering methods for those women. So if you just go off it immediately, almost everyone will have a significant surge, has been my experience. And so if you're on patches, it's like you skip one patch per month and then, you kind of play with it until you taper down to one. And so that seems to be better. But I think if you have bleeding after, pulling back, that is definitely a reason to be evaluated, just like it sounds like you had, to make sure there's nothing else going on. Do you guys have other thoughts?
I think it's an important thing to understand that if you're taking hormone replacement therapy and you come off of it, almost everyone, even if their ovaries have stopped working, has some hot flushes because you had here and now you're here, and that up and down is what bothers us. And so just about everybody has some hot flushes after stopping their hormone replacement therapy. So I think that's important to note that it's not, just by taking hormone replacement therapy, you are not going to just skate through it. You will have something. Is it common to spot 4 to 5 days between periods? And this related to perimenopause?
I would say generally we would consider that, although it can be very irregular, as we talked about during the perimenopause, generally, if you're having spotting in between, it's really important to be evaluated to make sure there's not something else going on. Women can get polyps or fibroids or an overstimulation of the lining of the uterus called hyperplasia. And so those are things and cancer as well can cause that. And so those are, reasons to be evaluated. And so I would say that it could be normal, but it would be more concerning to me as opposed to having your periods more spread out or closer together.
So the question is, once you're postmenopausal, is there an increased risk of yeast infections and other vaginal things?
So the answer in general is that you've lost through menopause a lot of the protective secretions that keep you from having infections of any kind. And so the answer generally is yes. In particular, yeast infections, not necessarily. But when you go through menopause with the dryness that happens and the atrophy, which is kind of a shrinkage and dryness of the vagina, you do lose a lot of the protection. And you also get an irritation that isn't necessarily an infection, but it feels like it. So it's called atrophic vaginitis, and it just means inflammation or irritation of that area that's caused by the lack of estrogen.
So, and one note, because the background of this is the vagina has normal bacteria in it. It's supposed to. That is how we are made. Yeast infections are an overgrowth of the small amount of yeast we're supposed to have there. Bacterial vaginosis, which is another sort of infection, is an overgrowth of other bacteria. So there's normal good bacteria, overgrowth of bad bacteria, overgrowth of yeast, but there are other skin diseases that you can actually get in the vagina. So absolutely, you can lose some of that normal bacteria and that normal flora, which increases your risk for bacterial vaginosis and yeast. But actually, older women are actually also more likely to get skin diseases of the vagina. So, yeah. So the vagina is actually skin. You didn't know it. So the question is about the over-the-counter Refresh and things like that. Refresh, and most of the over-the-counter things are vaginal moisturizers. They don't replicate completely the flora and the normal vaginal secretions entirely, but they do provide a little bit of longer-term moisture. They usually last about 4 days. And then the follow-up is, are the vaginal estrogens going to help? And the vaginal estrogens do help. They help you restore your 45-year-old vagina. You're not going to get to a 20-year-old vagina. You're going to only get back to a 45-year-old vagina.
I want to say one more thing about that product. The Refresh is actually designed to normalize the pH of the vagina. So that's the sort of the environment in which the normal yeast and bacteria grow, and that can be messed up. If you have chronic infections or on antibiotics for a long time or whatever. So that particular product that you mentioned is supposed to restore the normal pH, and that can be good.
The question is on antidepressants and when to come off of it, which I think antidepressants, clonidine, gabapentin, you've all, I mean, if they work for you, great. But then what do you do? Do you know what I mean? Do you just stay on these forever? And in my experience, I generally every year or two try folks to come off of it. And you have to kind of give it more than just a couple of weeks off of it, but they can be really miserable for those couple of weeks because it really needs to your body needs to sort of reset. Some people lower the dose sequentially and really kind of come off of it slowly, especially with gabapentin, that's important. So there are some options there, but every couple of years, it's hard because you don't want to be miserable. And if it's helping you, and you don't want to be miserable and you're not having side effects from it, I'm hard-pressed to say you have to come off of it. Now, it may be that we just don't have the studies to say. It may be that there are no long-term effects to taking it, but certainly if you're really getting that much benefit from it, I'm hard-pressed to take you off, but I'll give another person a chance.
You may know about this already, but there is a new formulation of Paxil that's a very low dose just for hot flashes. And so you may try transitioning to that.
And is it Paxil?
It's called Bristell. I think it's Bristell. It's a like a 7 milligram versus 75 or whatever else you might be on.
So for the cameras, the question is on hormone replacement therapy in someone who went through surgical menopause, had both their ovaries out, and dense breasts, which is a whole big another topic of the world, and fibrocystic breasts or cysts in the breast and that sort of thing. And I'm going to give somebody else that
So
one.
there is a correlation between hormones and dense breasts. I mean, some women have dense breasts, period, but when they're premenopausal, producing their own hormones and on hormone replacement, that'll continue to be more than if they stop the hormones. When they stop the hormones, I should say, then that density will decrease, and so will the cysts. But there's a baseline density that everybody has, more or less, but the hormones just make that more pronounced.
And the question is about genetics and cysts. There seems to be some families seem to have ovarian cysts, breast cysts, and that sort of thing. And should people be concerned about that?
I'm not totally sure about the link between breast cysts and ovarian cysts. I know ovarian cysts, there can be a hereditary link. So that is something for her to think about. And that actually, one of the best ways to suppress ovarian cysts is actually being on the oral contraceptive pill because it prevents cyst formation. It doesn't treat current cysts that are there. I don't know about do you guys have any thoughts about the breast and ovarian cyst formation?
This is a weird one because the evidence we have says no, but there certainly are people who swear up and down that everyone in their family has ovarian cysts and breast cysts and ovarian cysts and breast cysts. So it's probably true that there's some genetic link for some people, but we really don't know for sure, and we don't know what that genetic link is. But yeah, I do have patients who are like, no, everybody in my family has ovarian or breast cysts. So the question is on polycystic ovarian syndrome and progesterone. So polycystic ovarian syndrome is, so syndrome, first of all, when doctors say syndrome, it means we don't really understand it very well. That's doctor speak for we don't know. But there's a connection between people who have a bunch of small cysts in their ovaries, hormone imbalances, generally too much estrogen, too much androgens, and irregular periods. That's the three things that tend to go together. And the problem is that those people with PCOS are at increased risk for developing uterine cancer because they have this chronic exposure of estrogen to their uteruses. And so the recommendation is that they be on some sort of hormone suppression, either a birth control pill or progesterone. She is doing the right thing. The problem is with the migraines that she has, estrogen, in people who have migraines with aura, estrogen increases your risk of stroke. So only in that small group with birth control pills. So it's a very complicated thing. She's got two kind of things that she's trying to kind of wean through, but progesterone's a really good option because she really does need it. Sorry. Question is on intact uterus, intact ovaries, looking for hormone replacement therapy for hot flushes, and the patient was put on estrogen only versus estrogen progesterone. Melissa, you were starting. I'm going to let Melissa talk about it.
My only thought that, because this is really this isn't a new thing. This has been known for a long time that you can't give systemic estrogen without progesterone. So could it have been a vaginal estrogen and she just... And she doesn't have a Mirena IUD because there's a progesterone secreting IUD that some women are doing with oral estrogen and I guess just to give a little background about why is that a big deal is, so when you have your period, the first half, you tend to have high estrogen levels and then you ovulate. And when you ovulate, the little cyst on your ovary secretes progesterone in case you get pregnant to support the pregnancy. And that progesterone, the estrogen in the first half builds up that lining of the uterus, and the progesterone tends to stabilize it. And if you don't get pregnant, that we call it the progesterone withdrawal, people, the decrease, that drop in hormones is what causes people to shed that lining and have a period. So people with PCOS or don't ovulate very often, and so they get the estrogen. They kind of are stuck in that first half of the cycle, and they don't ovulate, so they don't get that little cyst that produces the progesterone. And when you have chronic estrogen exposure, that lining keeps building. It never gets the stop sign to stop building. And when you keep building and building and building, the risk is the increased thickness. You're at increased risk of abnormal cell formation. And initially it can be something like, we call it hyperplasia, so that the cells look abnormal under the microscope. And eventually with chronic exposure, we know for a fact that it can lead to cancer, endometrial cancer, which is a uterine cancer. So cancer of the lining of the uterus. And so that's why it's a big deal not to just give someone who has a uterus estrogen, because we know that is a real risk to someone. So
some timey doctors, old-time gynecologists used to do a lot of weird things with estrogen shots and estrogen by itself and estrogen by itself, and then do an endometrial biopsy, once a year or every 6 months. But in general, it's not a good thing to do unopposed estrogen.
That hasn't changed. Right. And there are caveats. Yeah, there are caveats. If you're giving it just for 3 days, just to stop an acute bleed, there's lots of caveats there. So, it's hard to say that they're doing right or wrong, but in general, we don't give estrogen without progesterone. So the question is on the best course of action in perimenopause. And the problem is that it's so dependent. It's dependent on your family history, on your personal history, on a bunch of other stuff, on how much all these things are bothering you. Should really, do you know what I mean? Like, to get too far into it, that's probably why you should talk to your OBGYN about it, because it really ends up being super, super individual and personalized what people in general are supposed to do. I don't think there's a perfect answer. Some people should be on birth control pills. Some people should be on hormone replacement therapy. Some people should be on nothing. It really just depends. So I know that's an unsatisfactory answer. I do know that, but it's the truth.
I would just say optimize your health as much as you can with exercise and diet. We talk about all these medications, but ultimately there's so much you can do without any of those things. And this is a good time before you're miserable to really optimize your health going into this transition.
Well,
So-
I would recommend tapering off. So if you remember in the studies that I mentioned, it was mentioned over and over again, within 10 years of menopause and up to age 60. But so when WHI first came out, the first change was, okay, let's only treat for symptoms, so for menopause symptoms, and let's treat for at the lowest dose effective and for the shortest amount of time. And that amount of time was about 5 years. So I think that one very reasonable option for you would be to start tapering down. And there are lower doses, and I do it very slowly with my patients, even a year at a time. Let your body adjust, and eventually you'll get down to a low enough dose. And over the next, for you, maybe you're 53? So you're fairly close to the natural average age of menopause, which is 51. That's where you start counting. Even though you had your hysterectomy in your earlier, women who have hysterectomies early in life, late 30s, early 40s, are recommended to stay on hormone replacement at least until average age of menopause, which is 51. But that would be with ovaries removed. Yeah, that would be my recommendation.
The lowest dose.
Right.
So just take.
You taper down, you start skipping every other day, that sort of thing, but over a long period of time.
The question is coconut oil for lubrication. So totally magic. So you can use any natural vegetable oil as a lubricant. You absolutely can.
You can use egg white.
You can use egg whites. Right. So coconut oil, I know they're laughing at me in the back. You actually can use
Look
any
at the
natural
kitchen for whatever you have.
vegetable oil. Absolutely. Yeah, sex should never be held back by your lubricant. But yes, you can use coconut oil. We don't know about the antibacterial or any of those other effects that hasn't been studied, but it is safe to use vegetable oils. So the question is on the vaginal ring, which puts out low dose estrogen into the vagina for 3 months, which is kind of awesome. But her friend started noticing vaginal discharge with it. And is that common?
Yeah, that's the estering. And so that's a really good option for anyone with vaginal atrophy, and especially older women who it's hard to, or who have mobility issues. So it's difficult to actually place tablets or creams in because they can actually just come to the office every 3 months and have the ring changed out. And anytime there's a foreign body, I would say, inside the vagina, it affects the flora and fauna. And so there can be a buildup, and potentially that can lead to probably maybe bacterial vaginosis is what I'm thinking.
Yeah, it's
maybe
not
the
a
issue
common
is.
thing. It's not something you would expect to have. So
Yeah.
it is something that needs to be looked at because it could be an infection.
Yeah, if you have something inside your vagina and you have new symptoms or change in symptoms, you have to be seen. Discharge, odor, bleeding, you should be seen. So this question is about SERMs again. So the SERM that we were talking about is actually just for vaginal dryness and atrophy. It's actually technically approved, I think, just for dyspareunia, which is painful intercourse. So it's really aimed at that. We don't have a SERM, although God willing we will, that sort of addresses menopause symptoms and still anti-estrogen in the breast, because that would be kind of awesome, wouldn't it? That would be the solution to it all. We don't have that yet. So just for vaginal atrophy. It's a really interesting question because the question is on BRCA1 and BRCA2 and hormones. I would say your breast surgeons would say absolutely not, never do it. Are there people doing it? There absolutely are. They're taking some risks.
What if you've got a mastectomy?
They're taking some risk. A mastectomy probably doesn't remove every cell of breast tissue, and so that's always the risk. So again, do you know what I mean? Like we talked about, there are risks in life, and some people feel like it's absolutely just worth that risk. They will take a recurrence of their breast cancer for how they feel. And it's crappy that we're in the position of having to make those decisions, but that's the reality. So sorry.
There's another SERM that we don't give for hot flashes, but we give it for some women for bone health called a Vista or raloxifene. And that is also breast protective. And they're looking at giving it to women who are at higher risk for breast cancer, that it those research studies are being on, but the unfortunate thing for that one is it tends to give you more hot flashes.
Right.
So these SERMs, I think it's a really interesting area of research, and I bet they're going to keep modifying those to try to optimize all the right receptors that we're looking for. But
So we are out of time. The Bing Lounge is going to bust us out, but we'll be in the back. Also in the back, lubricants, moisturizers to feel, little tissues to clean up with, and some books that might be helpful because they're actually really pretty balanced and pretty good. Thanks, guys.